Not yet?
4.013.
You're gonna start.
Okay, Dr. Seung Ba.
Good morning.
Okay, welcome you to India Live.
Okay, can you hear me, Dr. Lee?
Yes, we can hear you.
Okay, all right.
So
Great. First of all, I'd like to thank the organizing committee for inviting us to this fantastic meeting. And really, we are very happy and honored to prepare some cases today. So, operators, Daegu Park and Lee Chul-hyun and our colleagues, and we have, as you know, a limited time, and so we are going to directly, get into the live cases. So, Dr. Lee, could you see that angel in the auditorium? Okay, live case
Okay, yes, and we're gonna briefly comment on the patient history. And this patient is a 49-year-old male and with admitted with upper chest pain. It's clinically aggravating chest pain a couple of months ago. And the coronary angiogram and you can find and look at the patient history, and has no previous MI, no the PCI. And next. And the risk factor was hyperlipidemia as current smoker, as just a 49-year, very old, the young guys.
Right, relatively young gentleman. If you look at the patient, manifested with a stable angina, but the angiographic findings is really tough. It's a calcific lesion on the true bifurcation involved in the LAD ostium, circumflex ostiums, whether or not, Lamb's branches ostial part would be, involved with the disease. And would you show us a spider view? Okay, in the screen?
Yes.
Okay, clear. All right. The spider view clearly show us a truly, bifurcation disease, and the main bifurcation disease involved in the LAD ostium and circumflex ostium. We don't know yet, but Lamb's branch is ostium too. So would you show us the other view and AP cranial or something? Okay. All right. If you look at this, there are some critical stenosis of a circumflex and diagonal branch ostium. I think it's a pretty big ones, more than 2 and 2.5 vessel. And there are another disease in the mid portion of LAD and the tortuosity and some, disease on the mid portion of LAD too. And so, actually, the right coronary arteries would be okay, right? And so, totally, relatively young, gentleman. However, the atherosclerotic burden, the disease entity is pretty, big, severe disease of left main and diagonal branches and mid LAD disease too. And so, Dr. Lee, what would you do that? Would you discuss about strategic concerns?
I think this is a very tough means trifurcation, true trifurcation, and mid-LAD also bifurcation involvement and long lesion.
Yeah, right.
So Dr. Matthew?
Yeah, good morning. I totally agree. It's a very, very complex disease. But
Matthew, how are you?
Good. Hi, how are you? So, what do you? In general, we tend to say that if the circumflex disease is also involved, they are better off with surgery than angioplasty. Do you believe so? Or
Yeah.
So would you like to go for surgery?
All right. All right, this is very complex disease subset. So maybe it's one of the good candidates for bypass surgery. However, I believe main disease, I think, is a little bit different, clinical outcome by PCI treatment in terms of if you can fix up. So I, to be honest, I want to do kind of complete revascularization for particular this patient. The reason why he is still very young, all right, and there are some diseases still active in the socially, and so I want to make some complete revascularization, including the diagonal branches and the mid LAD, and if possible, true bifurcation disease too, right? So it is very difficult, and so in every cases for the main disease, actually we're gonna do the IBS, dependent procedure, IBS guided procedure, and so we're gonna do to save the time, so IBS examination for the diagonal branches and LAD, and multiple view from the LAD and circumflex, and so. Dr. Bach, would you explain that one?
Okay. Could you
diagonal
show
first?
Yeah, this is the diagonal branch intravascular ultrasound. Okay, Lon. We checked the vessel size of the diagonal branch, and that was the part of the diagonal branch. And the vessel size was 2.5, and so
ostium.
Look at the ostium, diagonal branch ostium was very tight, the encircling of the large amount of the plaque, and then next LAD. Yes.
LAD on from the distal?
Yes, and we also checked the LAD. That portion was distal part of the diagonal branch, and the vessel size was not so big, 2.75. And this is just the lower part, distal part of the diagonal branch, and look at the diagonal branch coming from the 3 o'clock, and that area is the vessel size was just 3.0, and the diagonal branch ostium was there is some larger plaque, and this is the just the proximal part of the LAD branch, and the vessel size more than 3.0.
Okay, so. All right, to simplify the findings, anyway, the ostial part of the diagonal branches, they're pretty much plaque, discrete stenosis,
right.
But there are significant disease. And distal part of LAD region is, far distal part is relatively negatively related with the negative remodeling. Right. However, the disease part, the vessel size is not too big one, so 2.5 something.
Yeah, right.
And, okay, would you show that? Okay, go ahead. And getting bigger to 7.5 serial, and after the merging with the diagonal branches, it's getting bigger 3 or 3.5,
yeah,
right?
Right.
And then, why don't you show us the LAD and the main and circumflexor limb main too, right? And so we have a total, understanding so from the IBS findings, and then you're gonna do, decide how to treat particular this complex region subset, right? Okay.
이게 어디죠? This is we already treat the mid LAD part. This is the IBUS from the prox LAD, the stent area, and to the left main.
We're gonna explain the later, right?
Yeah, right.
Okay, this is prox LAD.
Yeah, this is prox LAD. The vessel size was the diameter was more than 3.0, 3.5, and there was a huge plaque and the encircling plaque. This is the prox LAD, the LAD ostium part, and we did the balloon. There is some severe dissection, and also, this is a LAD ostial part. It's very tight region, and this is the coming ramus branch, and then we put the suck was also there was a severe atherosclerotic. This is distal main. We can find some dissection, and the vessel size was 1, 2, 3, 4, and there was a huge plaque. It's a 12 o'clock part, and the plaque was extended to the shaft. Plaque was extended nearly the shaft and ostium of the left main ostium. This is more than 4.5.
Okay. Would you show us circumflex?
Yes.
Okay. So based on the angiographic findings, we did, all branches, IVUS, and we have a more understanding what, characteristics would be in the inside of the vessel. Okay, start with big vessel, circumflex.
This is a circumflex. At first time, the people pre-dilation is the IVUS does not pass, and after dilation, we can see is very tight, huge block. Can you show again the sarcoosteum?
Osteum.
Yes. The region length is not so long. Okay. This is the sarcoosteum. It's very tight and nearly totally encircled plug of the sarcoosteum, and then plate. And the added osteum was coming. Its plug was definitely extended from the prox LAD to the distal leg main.
Okay. That's clear. Again, there are lots of plaque burdens, the prox LAD and distal leg main, and circumflex osteum too, right? Reference vessel diameter is at least 3.0 for the circumflex and 3.5 something in the proximal LAD, right? And so we clearly we've seen that from the IVUS findings, there are much plaque on the circumflex osteum, LAD osteum, and diagonal osteum, and with the LAD part too, right? And so significant disease, hold the branches, and so I'd like to ask, some discussion about how do we have to, treat this one, right? Dr. Lee.
What about RI osteum? It was also involved, or ramus intermediate osteum?
Yes, RI by IVUS from the LAD osteum to the distal main. RI osteum looks okay. Just the plug was confined to the sarcoosteum.
To be honest, we have spent a lot of time to do IVUS, some procedure, and so by angiographic findings, we are sure, Lamb's branch would be okay, and so we're gonna do, So what about the treatment concern, Dr. Lee? Would you discuss that?
Dr. Matthew, what about your opinion?
I mean, once you have decided to treat, I may put wires in all the major vessels and then probably separate out the left main from the LED diagonal. We'll deal with one at a time. If I have to do, I will separate out the LED and diagonal, treat that separately. Fix up that and then deal with the circumflex and left main together and then try to combine together with multiple balloons. That would be my strategy. And any comments from our moderators?
Right.
Of course, Renu is sitting here. You will be scared of her comments. He would disagree with all of us attempting all this.
Dr. Sharma, any opinion?
I would say that this patient should go for surgery. It's too complex. And I agree with you. When you have circumflex involvement, osteum, you have to think twice. But here we have an expert who's doing it, so I don't want the whole audience to think they can tomorrow tackle this kind of lesion. Perhaps only you can do it, so therefore I will let you do it. But I would have thought that the LAD was the dominant vessel, is the larger vessel. So I would want the last area to be stented going from the left main into the LAD rather going into the circumflex. That's just the way I'm thinking.
Okay, so you prefer...
okay, Dr. Lee.
Yes.
But there is a, madam, there is a significant size discrepancy between left main and LED. You see, circumflex size seems to be bigger than the LED. So,
okay, go ahead.
Okay, so anyways, we're gonna do fix up LED diagonal first, and then focus on the true left main bifurcation disease. And so, in terms of clinical outcome concern, Charan Lee, Dr. Lee, would you comment about the surgery versus PCI outcomes for particular these patients? Actually, can you expect in terms of a limited bifurcation, left main bifurcation disease, and simply LAD and diagonal disease? And so, would you tell us some database comment, Dr. Lee, from the meta-analysis?
According to this pre-combat trials database analysis, limited left main disease confined to osteosharp or non-bifurcation left mains, the result of this PCI better than this cabbage in terms of hard clinical outcome. In case of true bifurcation, just like this lesion or limited left main plus multivessel disease, both treatment is similar. I think this maybe similar outcomes between cabbage and PCI in this particular situation.
All right, based on a large-based, the registries, the meta-analysis, and so we got some idea, especially for the main PCI, as quite, comparable clinical outcome with the bypass surgery. If we can make I think it's a complete vascularization and, a perfect, procedural outcomes, right? Okay, so Dr. Ba, would you explain, we're going to, save the time.
Yeah,
right. We have already done diagonal branches. And so from the beginning, we're going to plan, so LAD diagonal crush and consecutive kind of a LAD and circumflex crush, right?
Yeah, right.
So would you explain that, what we've
Okay,
done?
so and our strategy was very straightforward, and we did 2 crushes, the LAD diagonal and the distal main. Okay, next. Next. Okay, we put the wire, is the intermediate wire and diagonal branch in LAD, and then next. And then distal, this is next.
Slowly.
Okay.
Would you show previous one?
Okay, previous view.
Okay.
Okay, we can find the distal part of the mid-LAD bifurcation lesion. We can see that there is definitely the disease on next. And next. And then we put the, previously we put the distal part of the LAD 2.5. This is the diagonal branch is 2.5. And then we did the balloon crush and next. And then slightly pull back and high pressure balloon to ensure the ostium of the diagonal branch was bigger and next. And then they remove the guide wire and the stand, and then pre-dilation using the non-compliant balloon is 2.75. That was non-compliant balloon, and next.
Kind of a balloon crush, right?
Yeah, that was,
balloon crush
balloon
first.
crush. Okay, next.
Still, there are some disease of main, right? We have to fix up that, and so we would like to less damage to the main vessel disease, and the reason why we're going to try the balloon crush first, right? Rather than the two-stent crush, right?
And then after balloon crush and we check the coronary angio, you can find that there is definitely the disease from the mid-LAD to distal and main. And next. And then we put this is the 2.5, and the giant stand is jet 23, and the next. And then this is the view, and next. And then we put the additional balloon. This is 3.0 stand, 275. And 18, and the giant stand, and next. And then we did some more high pressure balloon, and next. And then we did the part as to make sure the ensure of the POT area. Okay, next. And then look at the angio view, and then next.
Quite good, right?
Yes.
Before the crushing diagonal LAD, and still quite good angiographic findings. So, okay.
After part, and then we crossed the wire, the diagonal ostium using the choice PT hydrophilic wire, and the wire was distal easily passed. And then we did a small size balloon, 1.25 compliant balloon to open the diagonal ostium, and next. And then next. And then we did the non-compliant, 2 non-compliant balloon is high pressure, is to make sure bifurcation, the morphology was better. And then we did, this is the 2.5 non-compliant balloon, LAD part is 2.75 non-compliant balloon. And we did consecutively balloon dilation next. And then diagonal ostium next. And then this is added ostium next, sequential high pressure balloon, and then the kissing balloon dilation is like some the snuggling method.
Just above the LAD vessel size is not so big one, and so we use the 275 LAD 2.5 diagonal branching, and kind of make mini.
Yeah, right.
Mini kissing, right?
Right,
mini
right.
kissing.
Mini
All right,
yeah.
I don't
That
know.
was,
Mini kissing.
yeah,
It's not too much overlapping.
Yeah, right.
Okay.
And then
next.
And the mini kiss and the next.
Kissing.
And then the result was excellent for LED part. And then next. And then
what do you think? All right, would you show the previous one?
previous view.
Okay, that is the first part of our procedures. It took a time, it's 20 minutes something, and then we deployed the 2 stand for the diagonal branch and the LED
right.
and the finalized final kissing balloon inflation too, right? So what did you do there? In the result-wise?
First part is
That's
okay.
good.
Now,
All right, so we did already post dilation,
Yeah.
275 kissing balloon inflation.
I mean, no doubt, this is an
So-
excellent job.
Yeah.
All right. So this part, the first part, the diagonal and the LED crushing is quite not too complicated. And then we actually focused on the main, true main bifurcation and the LED circumflex, right? And
Right.
that's the next stage, right?
Right.
Okay. So would you show the next
First
section?
obstacle was rapidly resolved, and we're gonna focus on the distal and main. That we put the
So would you tell them anyway? Do we have very much difficulty to
right.
wire pass
Yeah,
for the
right.
circumflex ostium?
right.
It's a too steep angle. There are lots of plaque burden about circumflex ostium,
Yeah,
right?
right.
And then
for the circle branch, we put the intermediate wires. The wiring was at first time not easy, and the SJ Frog is tried to overcome that the angle and successfully passed the intermediate wire to the circle ostium. Initially, IBUS does not pass. We did the balloon dilation on next. And then next,
Now,
we
there are
need
some, just previous one, there are some dissections on the prox LED, big dissection, and a little bit compromised, LED anterior floors. The patient have some symptoms, chest pain, the blood pressure is a little bit, going down, and so we to be, honest, we cannot wait
right.
to show the true
at this point, I have a question.
procedures. So, and then,
At this point, SJ, I
Okay.
have a question. Now you have a dissection reducing the flow into the LED. And so all your strategy now would be involved protecting the LED. You have to now treat the LED probably first. Before that, with the 90-degree takeoff of the circumflex,
all right.
what would have been your strategy, whether it is going to be a tap, whether it is going to be a culotte? What was your strategy to begin with? Did you change your strategy and decision seeing this LED dissection?
Could you tell? Yeah.
yes, that is not each question. If first the wiring to circumference was failed, and as you suggested, the tap technique or culotte technique we should consider. But successfully, we passed the guide wire, the circle ostium, very lucky, and so we just decided to the crush technique. As you mentioned, if there is some dissection flow limitation, if you should focus treat the LED first, and we consider the culotte or some tap technique.
Great. To be right, based on our data, actually we have lots of different two types, two-stand techniques. And the culotte technique, as you saw, this tap technique, the mini crush, etc., etc. However, I think it's a clear, based on the operator discretion, right? Operator preference.
Yeah, right.
So in our lab, anyways, we are a little bit, familiar with the mini crush technique. The reason why I think it's relatively more safe than, more safer than the other, and very simplified concept, simplified, procedures. And so, anyway, at these times, actually there are some difficulties to cross the, IBIS cluster for the circumflex ostium, and there are some dissection. Patient had some symptoms, and so, we just, proceed our procedure, right? So, okay, what is next?
Next. And then we did a balloon dilation. This is non-compliant balloon 3.0 to suck. And
high pressure?
High pressure. And next, there is some slight kinking and additional high pressure. And next, and then there was the dilation of the suck ostium. And the next, LED ostium was much compromised.
Right,
so we quickly do the next stenting
to
procedure.
be honest, we cannot wait, right? The patient had the chest pain.
Yeah, right.
So, all right. So actually, we want to show, we want to show this part, and
Okay.
so what is next?
Okay, next. And then we decide to the crush and the balloon crush. This is the LED part is 3.5. Non-compliant balloon suck is 3.0. 15 giant stand. And next. And then next. And then we try to make sure the ostium was attached balloon. And then we did the balloon, the stand implantation, the 3.0 at the 15. And then next.
Okay, exactly same with the two stand mini crush technique. However, there are too much compromise of LED floor, and so we don't make a too complex two stand procedures. And we deploy the circumflex stand first.
Yeah, right.
And then the proximal part of a stand is crushed with a balloon, non-compliant balloon. And we're gonna make a more, easy procedures. Okay.
Okay, next. And then the slightly pull back, we did additional high pressure balloon and the two easy side branchy, and then remove the balloon, pull back the suck ostium.
I like this part. For the in case of a mini crushing, just the balloon standing, the side branch and pull the hold of
And next
device. I think it's okay.
Right.
All right. And
then we did non-compliant 3.5 non-compliant balloon is balloon crush and the high pressure next. And then the flow was much better and still compromised. There is some dissection. We decided to put the stand directly. Okay, next.
Flow is improved.
Yes, but
however there are some big dissection on the just distal part of the main and consecutive polygonal confluent areas. There are big. Any regional, dissection of prox LED. And so still we cannot wait, all right? And so, what is next?
Okay, next. And so we decide to, this is a 3.5 and 33 giant stand. And then next, and then we try to cover the whole, there is a checking the overlapping area and next. And then try to cover the whole part and next. And then this is the part, okay, and then try to
match it with main ostium too, right?
Yeah, right. Next, and then this is 3.5, 33, and then we did stand implantation, and next, and then we next we checked the coronary angle. It's okay. Yeah, that was we did the procedure at this time. And then
spider?
Yes, spider view.
One more view here?
Yeah, okay. Angel ready? Shoot. Okay.
Very nice.
Great.
All right. That is the final. Final angiograms. After the two stent crushes, LED diagonal, and we believe Lamus branch will be okay, right?
Yeah, right.
The ostial part will be good, and so we deploy the circumflex, balloon crush, and finally, LED and main stand overlapping, right?
So we still didn't yet the kissing balloon dilation for the distal and main. So we'd like to quickly demonstrate this kissing balloon dilation. Before kissing balloon dilation, to make sure the easy accessibility of the side branch of the ostium and also make the good result, we did the tap technique. This is 14, 4-0.
Could you see?
Okay, test it.
Can you see that?
Okay.
Okay,
can you see that? Okay, go. 10, 12.
This is 4.
Yeah, this is 4.0.
4,
10, 12.
Non-compliant.
Yeah, okay.
Hyperinflation, right? You know that the part technique, the proximal optimization of our main. Okay, one more.
10, 12, 14. Okay, save. Deplete. And then we try to oppose the prox part of the stand. And
Okay, I'll take it. Okay.
여기서 오스까지 한번 보겠습니다.
Okay, here we are.
오케이, 한번 밟아보겠습니다.
More.
오케이, 오케이, still. 오케이, 자, go. One more.
This is 4.
10, 12, 14. Okay.
Very proximal main
Okay,
and
safe.
proximal
Flip.
part of shaft is, you know, optimized for
자, go.
high pressure inflation.
Okay, to make sure to remove the inner position of the prox part of the stand. Okay, deeply. And then we like recross the wire to the circle ostium using the hydrophilic wire.
Okay, would you show us some angio for us?
Okay, got it. Okay.
Picture?
Okay, angel ready?
Yeah, ready.
Shoot. Okay, great. 자, choice
I like
wire. Okay,
So
we
basically, excuse me.
Yeah, the 4. The
Okay.
additional balloon is 4, but the original distance size is
choice PT.
And then, and basically the disease is very much calcific disease, right?
left
So
main is heavily
after the
pressed.
4 hyperinflation, still there are some, you know,
Yeah, right.
all right. I think it's okay. 나는 너무 어그레시브 안 했으면 좋겠어. 이게 프록시멀 랩 메인에
네.
약간 다 섹션했어.
아,
에어를
네,
다 쌓여.
네, 네. 저도
뭔지
아까부터 네.
Okay.
섀도우가 보여서.
Okay. I'll see that. Okay.
This is a choice PT wire.
Gently.
Okay. And then try to keep the past the inner side of the stand. Okay, this is easily passed.
What kind of wire?
This is choice PT hydrophilic
PT.
wire. That was our nearly routine. Yeah. Okay. Test.
Just
Would you like?
maybe
Okay.
we need another little more car. We have actually very limited time, right? So
You have 10
the
minutes.
reason why is we have already. Okay, good.
You have
I
10
like it.
minutes.
Okay. Just 10 minutes. Okay.
All right. 10 minutes is enough. All right.
Okay. Test.
The arm sprinters.
알아요,
You may need a little bit more car. Okay.
Okay.
While changing the curve, what is your comment about
Lino?
the second
Just make.
while changing the curve and accessing the circumflex, just asking, is there any difference between the second generation stent and the third generation, fourth generation stent? Is there any advantage or all are the same?
No, I'm not sure. To be honest, I'm not sure. You know, different. We have a lot of data in terms of the main PCIs from the first generation of drug-eluting stent, Cypher, even Texas. I don't like Texas, right? Any second generation of drug-eluting stent, we didn't make any difference in terms of the main PCI. The reason why, you know that main vessel itself is a pretty big one, right? Big effective stent areas, you know, relatively lower frequency of stent thrombosis rate, et cetera, and so. To be honest, I don't believe too much of a different type of, you know, drug-eluting stent can make a different, different clinical outcome. So there are some advantage and disadvantage in terms of, you know, side branches, size, something. However, still, you know, it doesn't matter. It's not a big deal.
Okay.
Dr. Matthew, sir,
Still,
I have one small
down
question to you.
practice, we need a.
Actually, this is what I want to know. Once now the Indian government, according to Indian government, the all 4 generation stent seems to be same. Earlier, patient used to help us to choose the stent. Now, once the all stents are less than $500, now it has become more difficult for us to choose. So,
No.
so which stent, which artery, which stent?
Don't mix up
choice를 줘봐.
don't mix up academics with government. Government has, uneducated people make decisions, we may have to follow it. That is unfortunate.
So which stent, which artery, which stent, sir?
Let us not get into that.
Which stent, which artery, sir?
That's what, academically, when you go into analyzing what we have to do, we should do what we think right. Don't just go by the politicians and bureaucrats should not dictate terms. We should go abide by our knowledge, our experience. Let us not mix up those things.
According to...
Very well said. I think it's the patient that matters and it's the physician's decision. It should not be a government decision.
Yeah,
I totally agree with you.
The patient's life, which we cannot, we have no right to take it away.
According to
Dr.
trial
Lee,
series, it's all the DS.
would you tell us
Yes.
some data?
Yeah, I said this is
Many kind of different type of DES. We have some clinical outcomes.
yes, we analyze this all different type of DES in the treatment of left main disease, all the same. So I don't think this, there is any differences according to type of DES.
No, only the other characteristics, the deliverability and other features what changes the outcome. We have
Okay,
still-
wire was
We have 6 minutes?
we have 5 minutes.
5 minutes.
That we'll manage.
So before
Okay,
rewiring,
got
I think this proximal
Okay, no
optimization is
problem.
very important.
okay. Yeah, right. Yeah.
When you face a situation like this, going back with another bigger size balloon in the left main, would you think it will help?
Yeah, there is okay, there is good one of option.
Agree. So it's a kind of you know, how can I say that? Kind of a pot techniques. So we're gonna make a little bit more curve for the. All right, this is leave that, and maybe the wire is passing through the Lamb's branches, and so we're gonna make a little bit more curve even there. And then I want to try that. It's almost, you know, 100% we can.
Dr. Park, your transmission time, do they allow us to come back and see your final result, whether we can go to the lecture, and would that transmission time permits us?
Great. Okay. So we're gonna consider, you know, proceed as our procedures. Okay. Anyways,
no, we have only just a few more minutes.
You wanna, you know, say goodbye?
Few more. Okay, got it. Yes.
Okay. 5 minutes more. Thank you for that.
Angry cursor.
I think it's just only, you know, it'll take time. So, however, it's not a big deal. Rewiring, so for the circumflex.
You are giving
if it doesn't work, we need another balloon.
You are giving us some consolation. We also
need another, you know, high pressure balloon for the.
We also struggle to get in sometimes. So it happens with you also. So some consolation.
네, 4.0 아까 나온 거 있죠?
Oh, really?
Angle is very stiff. So
Very stiff.
Okay.
Okay, good. Okay, great.
okay,
Wow.
okay.
All right.
Did you see that
It's
angle?
by
Yeah,
chance, and so I don't
Yeah.
believe it's a kind
wow.
of a technique.
Wow. Very
Wire just passed. I didn't do anything. All right. However, the end portion
Okay, great.
is
Okay, great.
look like all right. There are too much, you know, stent crushed area,
아까 나온
and so we may need a very small
Yes.
balloon inflation first, and it doesn't work. We're gonna have some, you know.
Okay, great.
Okay, still some struggling wire. The, you know, past area is good. It's very proximal part.
Okay, got it.
There must be more more crushed area over there, right? So I think we have some difficulties.
Yeah, right.
Even in the very small size 125 balloon. And so we want to make another balloon for the LED, right? 35, non-compliant, and balloon anchoring kind of things, right? And so why not? We're going to do 35, use one.
Okay,
for
35.
LED.
아까 나온 거, non-compliant balloon.
And then, okay.
자, 주세요.
35, use one.
We may
LED.
get cut off
Yes.
any time.
Yes.
We'll just
Okay,
watch for
got it.
1 or 2 minutes more.
All
Anyway,
right.
before we get cut off, thank you so much for a lovely demonstration
It's
and the
okay.
discussion. We may get cut off any time.
All right. All right. Okay. It's really our, pleasure and an
Yes.
honor to joining this meeting.
This is 3.5,
So, we are very
non-compliant
happy.
for the anchoring.
All right. This is useful.